Good afternoon. Welcome. It's 2:30 on Tuesday, so hopefully everyone's had some caffeine or some sugar or something. Lynda Rowe, Senior Advisor of Value-Based Networks here at InterSystems, and one of my many hats is to actually sit down and read US regulations and then try to figure out what the heck it means for our customers and our prospects, try to translate that into something tangible that our product management team can actually do something about, if it's important, if it's something we can do something, because not all regulations sort of fall into the purview of something that InterSystems technology can do, but I always think it's helpful to be aware because people ask me about certain regulations. I am not an attorney, I am not a compliance person, I just kind of, I get jazzed up reading regulations, yikes. So I am gonna go through a lot. So what I want to talk about first is sort of what is still going on now, sort of what already started and is in flight in terms of US regulations. And it's important to know that because when I start talking about what's going to happen, I'm going to refer back to what is happening, so if that makes sense. So I'm going to cover the ONC interoperability rule, which came out in 2020, price transparency, the CMS interoperability rule, which was from 2020, transparency and coverage, which is payers, and the No Surprises Act, and TEFCA. So that's sort of the wow. That's why I call this the regulatory tsunami, because I think every time we turn around, yet another rule drops, and we're like, oh no, what's up now, right? And then the new stuff. So we have CMS, advancing interoperability and improving prior authorization. There's a CMS attachments rule, and then ONC just came out with a new one while we were at HIMSS that was about updates to certification. So that's what I'm gonna cover. There's a lot more regulations out there. Sort of I focus on things that have to do with interoperability and things that would impact our products and our product set. All right. So let's talk about provider and health systems. So info blocking. So by now you are probably aware, it's sort of, ONC is saying, thou shalt share data. And you can't find an excuse to not share data. That's sort of what the rule said, right? Be good citizens, share data, you have interoperability, let's find a good way to do it. So, and the way they define it was, I thought, quite interesting. It was instead of saying, here's the long list of the 100 things that we think are info blocking, where it did the reverse and said, here are the exceptions, right? So here are the things that, where you can info block, right? So if you're trying to prevent harm, right? If you think what you're doing is preventing harm to someone, so if you think there's domestic violence involved and you don't want to share that record because you think somebody might get their hands on it, then that's sort of an exception. There are a couple that are important, sort of, because I'll get to them later. The content and manner exception has to do with how someone requests that information. So if there's a problem with the content or the way in which you're trying to share it and somebody says, I need that exception, you have to try to address that in a way that's not electronic. And by the way, this is all predicated on what you're doing is doing it electronically. And some people have this notion that info blocking was just about from health systems to their patients, but guess what? It's also about health systems to payers, health systems to other health systems, so it's a broader based sort of set of criteria. And I just like to talk about the fact that, sort of the way we thought about in HealthShare is we're really good at bringing in all the data because, by the way, this is about all the data. So it used to be just this limited USCDI, US core data set, right, that was part of info blocking. In December, it was what's called EHI, which is a designated record set according to HIPAA. That's a lot of data, and guess what? It doesn't all live in your EHR. It lives in your lab systems. It lives in your billing systems. It's any records that you as a patient could walk in the door and say, I want a copy of ... So just so you know, like some health systems have to realize that December changed the game. There was a lot more data that had to be shared, and that had to be shared electronically if they had it electronically. So the other part of sort of the ONC role where we played a role, it's funny because everybody calls it G10, but it was the FHIR APIs for certification. So part of promoting interoperability and part of the Medicare incentive program actually had the requirement that EHRs and or certified vendors had to provide data using FHIR for that USCDI and EHI data set. And so we had a number of customers come to us and say, can you certify on G10? And we actually said, no, but we can help you. We will make sure our technology is compliant so that when you go to certify, you will meet the criteria, and we did that for Indian Health. So Indian Health has their own sort of homegrown EHR. They're on our technology. They were able to certify for G10 using our technology. This is another one that was interesting. I heard somebody reference it, I think, yesterday. Event notifications were on the provider side. So again, it was the requirement that for any admission, discharge, transfer, that hospitals have to notify sort of who their patient wants to be notified. First and foremost, if I don't know, it's a primary care provider, it's a primary care practice, it could be post-acute care, or to me as the patient says, I want to have designated as my recipient. And the delivery mechanisms could be many. It could be SMS, it could be direct, because the payload actually didn't have PHI in it. It was intended to not have protected health information so that you could get that notification. Someone yesterday said, you know, great idea for a rule, too bad there were no teeth in it. So that's the problem. There's just been not a lot of regulatory enforcement around this one, but it's great that we are trying to get notifications out to people who need to know about transitions of care. So hospital price transparency is very interesting. It made hospitals make public their charges in two ways. One is, you know, a machine-readable file that they kind of shoved up on their website somewhere where people could go search for it. And the other was supposed to be in this consumer-friendly format for what they called shoppable services, things that you commonly would have as a procedure in a hospital. Many hospitals did not comply because the penalties weren't significant enough. And the Office of the Inspector General actually decided to make a point and find a few hospitals down in Atlanta, Georgia, a significant amount of money. They then went back and actually they reissued the ruling and they increased the penalties, and all of a sudden hospitals started to wake up and say, oh, maybe it's worth our while now to actually comply with this. But I remember I went and did some what I call secret shopping. You know, I went out to like all these different health systems in Massachusetts to see if I could actually find these files. I only found the file in one health system, and I think I looked at 5 different hospitals, and it wasn't very consumer friendly. But now my health system does push out to me. I got a notification that says, by the way, if you'd like an ankle x-ray, because we think you might like that, that would cost you, and I forget what it was, but I was like, really? Like, so I guess they're trying to do what they're supposed to, which is inform and educate you about the cost of services. So on the payer side, all right, 9115. So for payers in the room, they're really familiar with this. It applies to government books of business. It was not for commercial, although many payers said, you know, if I'm going to do it, I'm just going to do it for my entire population. It depended. There were initially 3 requirements. One was called patient access APIs. That was taking your clinical, your claims, and for some of the types of insurance, your pharmacy benefit, and making that available through FHIR-based APIs so that third-party apps and a third-party app ecosystem could bring that information in, and so that a member, as a consumer of information, could get that information in these third-party apps. And that went into effect in early 2021. Same thing with provider directory. It was sort of exposing your provider directory. It was a limited data set, but it's exposing it using FHIR APIs. There was no intended destination. It was more making it available, I think, for research or for others that might want to take different data from different health plans and aggregate that and kind of mix and match and look at that information. The interesting one, peer-to-peer exchange, was intended to go into effect mid-2022. And the problem with that particular requirement is that there was no specified exchange standard. It was like a free-for-all. You could send it as long as it's electronic, so you could send a Excel spreadsheet. You could send a CSV file, right? Can you think about what a hot mess the industry would be if like every payer is exchanging data on a individual member basis in different file formats and trying to ingest that? It just becomes not sustainable. So the payers kind of said to CMS, I think you need to take a pause. And so they put a regulatory hold, sort of compliance hold on it. And I want you to put a pin in that because I'm going to come back to what happens to that part of the rule when we get to what's happening in the future. But that was really, the intent of peer-to-payer was if I change payers, especially if I'm Medicare Advantage, because sometimes I shop every year to change Medicare plans or Medicaid plans, a lot of churn in Medicaid, it's intended to allow the new payer to know what's already been done. Have I already been given a prior authorization around services? Am I already in a diabetic management program? Have I already been diagnosed? Am I already on a tier 2 drug? All that kind of information so that when you actually start using the benefits of your new plan, that you're not starting from ground zero. So that was the intent. So the next rule, CMS transparency and coverage for payers, sort of the first, again, this was sort of the companion to what I talked about with providers, is to machine readable file on the website. Again, that was more for academic research, for those who actually wanted to go troll the data and figure out what the cost of different services was for different provider organizations, because that's what the plan has, right? They are putting out how much they contract with their provider network. Starting this year, internet-based services tool for members, around 500 shoppable services. I haven't tested this one out. I should go on my payer website and see if they're actually my payer portal and see if I can shop for services, but that's what's supposed to have happened. And then next year, it's sort of a self-service tool for members for all services. And again, as a consumer, everybody here, as a patient, if you go to your health plan, what you should be able to do is say, hey, how much would it cost me if I got a hip replacement at place A versus place B? Hospital A versus hospital B, as long as they're in network. And so again, the machine readable file was requiring monthly updates and had all things about, allowed amounts, billing charges. And if you're interested afterwards, I can talk about a use case that we heard about at HIMSS where one academic researcher went and actually pulled data from a whole bunch of different health systems to understand difference in charges in the same market. So pretty interesting stuff, what you could do with that data. And then the self-service tool is that, like I said, you have to disclose, different services, and I should be able to look and have information. And by the way, if I can't get it through the member portal, because I'm not a member portal kind of person, you should be able to call member services and ask for that information. So this is sort of what's impacting multiple stakeholders. So there's the No Surprises Act, and this is the act that came out, I want to say beginning of 2022. And this was, the intent is really good. This is to make sure that you as a patient never receive a bill for services that you aren't expecting. And when does that often happen? Well, an ambulance bill is a really good example, but a better one is sometimes when you go and have an inpatient procedure, the radiology images might be read by a radiologist who actually is not in network. You also may have an anesthesiologist who's contracted with a hospital but is not in network, which means you get billed a different amount than your in-network contracted rate, so you might get a surprise. Sometimes with emergency room, if you're out of state and you happen to go in an emergency room and they can't figure out your insurance, you may get a very big surprise bill. So that's what the intent was, but there are all kinds of things around this that they were trying to have a process, right? And one of the provisions is around the provider directory, because that is often a place of misinformation. So if I go to my payer and I am trying to find an in-network provider for my knee replacement or an orthopedic surgeon, and I find they're in network. And then I go, and the next thing I do is I get a surprise billing. There are some penalties that go both to the provider and the payer, and they actually have to go to arbitration to negotiate over who has to pay the balance on that bill. I, as a patient, can only be charged the contracted in-network rate because the information was incorrect around the provider directory. So that's a real forcing function. And again, CMS still has not issued final rules around a number of the No Surprises Act provisions, so some of this is still in flight. But generally speaking, the goal is to create it so that we as patients and consumers don't end up with those, oh my gosh, you open the bill and you say, how could it cost that much? So other provisions, there's this 30-day period for negotiation between providers and facilities, providers and their health plans with a backstop to resolve those payment disagreements. Like, all right, so the patient doesn't have to pay it. Who's going to pay it? Is the payer going to pick it up? Is the provider going to pick it up? For uninsured, HHS has to have a resolution process if the patient's billed substantially in excess of the provider's good faith estimate. So one of the pieces in this act is requiring for now, it's starting off that if you don't have insurance, so if you're self-pay, you have to get a good faith estimate from your provider about what your procedure or your visit is going to cost. And so what this is saying is if that charge is in excess of what that good faith estimate is, that I think there's like a 10%, sort of wiggle room there, but that you as a patient don't have to pay any more than what that GFE was. And so again, and then there's a provision that also has the payer sort of taking that good faith estimate, running it through the payment system without adjudicating a claim and saying, how much will it cost me out of pocket? Because that's different than what the provider is going to charge. So it actually figures out what's called the accumulator. So it figures out, my co-pays, my deductibles, et cetera, to figure out that. And so that's another piece that they're still trying to work out because there's some really thorny issues that have to do with who owns putting together that good faith estimate. So if you have multiple providers involved, they had this requirement or that called the aggregator, sort of the person that was the designated responsible entity that had to bring all the data together and then send that off to the payer and to the patient. And there was how do I get that? How do I get the bill, the charges from, the outpatient clinic that's actually going to do the pre-visit for that procedure I'm going to have? So they're still working through that. So that's why this rule is sort of in the air. And then there's TEFCA. And so hopefully folks have heard of TEFCA. It's the sort of framework for nationwide exchange. We had a lot of conversation about that earlier today. But it's sort of a framework principles as well as technical components. So sort of the regional coordinating entity is sort of ONC's designated organization that's managing the whole TEFCA program. And then under that is what are called QHINs. In my next slide, so QHINs have been, the first round of QHINs have been announced. There are others going through this process, but actually when you go through the first round with ONC for the certification, you're still a designated or a preliminary QHIN. You don't get certified until you've sort of operated for a bit. And then under the QHINs, you have participants, which could be health information exchange, it could be a payer, it could be a federal agency that could participate and connect to a QHIN. And so again, there are the permitted exchange purposes. So right now, under TEFCA, there are only 2 permitted exchange purposes. One is for treatment. The other is for what's called individual access, which means is I, as an individual, want to ask my provider organization that I want to connect and get data and pull it down through an app. They haven't quite figured this out, but that's what the purpose is. Because in essence, that's treatment as well, right? I'm a patient, I want my information. The next round will be public health. and healthcare operations. And they've actually put out requests for information around some of those subsequent payer use cases to allow exchange for payer purposes. But right now, if you sent out a query and you got data back, the only use case where you're required to send the information back is for treatment. So what's new? Again, the regional coordinating entity recently announced the first round of QHINs, QHIN candidates. So eHealth Exchange is an InterSystems customer. Epic, also an InterSystems customer. We're both announced. Health Gorilla, Commonwealth, Kanza, and No2. So those are the first round. I know there are more that are going through now that will be announced. And like I said, there are some proposed standing operating procedures for public health and health insurance. All right, so that was sort of a lot of stuff. So what's in the queue? What's coming up? What's that next wave look like? Because they're just not stopping. They just keep coming out. And every time I turn around, one of my customers will say, and what about this one? I'm like, oh, I haven't looked at that one yet. So, like inpatient prospective payment, I typically don't look at, but turns out the inpatient prospective payment rule is where promoting interoperability is embedded. So for provider organizations that participate in that, that's kind of where that piece lives. Okay, so CMS, following on to what we called 9115, the payer interoperability rule, has come out with what they're calling 0057P. P is for proposed, F is for final. The way a proposed rule usually works is that it will come out with a comment period, which allows industry to provide input and feedback on the rule. Once that sort of comment period has closed, the regulatory agency then has to actually adjudicate every single comment that comes in. And when the final rule comes out, they have to acknowledge, sort of either broadly or specifically, in the regulation, why they chose to do X versus Y. So they'll say, we chose to continue the rule as proposed, but thank you for your feedback on X, Y, or Z. Or they'll say, oh, based on the feedback that we got from you, we have amended, and the final rule will say something a little different. So it's very, very hard to plan when a rule is in this process on what the final rule will look like. So what I'm going to do is, I talked about patient access APIs, and that sort of, I said, put a pin in it. Here we are. What I want to do is talk about what's different. And it turns out, so the patient access APIs, sort of the APIs that is going to go to that third-party app, the only data stream that's going to change, it's going to add a new data stream. And that's prior authorization requests and decisions. So any information, so if you have a pending or active prior auth, that information will also be shared in that third-party app so that you sort of know the status of your authorizations. Other than that, things have remained pretty consistent in that particular requirement. There's a new policy that's actually saying that CMS wants to know how often members are accessing those APIs. And I can tell you that every time we convene as a payer work group, I ask the payers, so how many members have actually touched your APIs and used a third-party app? And it took a while until finally I think, oh, we had 2, but it's not taken great adoption. But CMS now wants to know, what does that look like? So how often is a member actually touching it? And then the second question is, do they come back more than once? So the next version is provider access API. So it's the same set of data, except instead of going to the member, it's going to go to your provider organization. The big difference is that when they send the claims file, they're not going to send payment information. So that's sort of proprietary, so that won't go over to the provider organization. It's also going to include bulk FHIR, so it's going to allow providers to get sort of populations of data as opposed to individual patients if they request it, so that I could send over a file and say, I'd like to see this cohort that I'm managing for an ACO, bring that data in, please. On the sort of standard side, they have identified the Da Vinci PDEX implementation guide is something we have been working on. We have kicked the tires around it. So, you know, when we saw that, we were like, okay, we got that. This is the tricky one. So, you know, I talked about not having provider remittances, but the two things that are interesting is, the first is attribution. If folks don't know what that is, it's basically saying, do I have a relationship with this provider? Is this provider my provider? And typically a payer will know that by looking at claims. They'll have some kind of file that sort of says, these patients belong to this provider, and if not, they often have logic to do that, because from a HIPAA perspective, if a provider is asking me, payer, to send data to them for a patient that's not attributed to me, I shouldn't be able to share that. So there's an attribution requirement that says, payer, don't send data to provider unless there's a pre-existing relationship. The second thing that I think is interesting is that this data sharing is going to happen unless the patient says, I don't want it to happen. So there has to be an opt-out provision. And if you think about, well, how is that going to happen? I think that generally it's going to have to happen through a member portal. So there's going to have to be some outreach from the payer to the member to say, if you don't want us sharing data with your clinician, if they ask for it, you've got to go to our portal and tell us not to do that. Payer-to-payer exchange. So 9115, they actually, in this rule, so when this rule becomes final, the payer-to-payer as originally written in the regulations will be rescinded, and it will be replaced by a new version of payer-to-payer that actually is using FHIR as the payload, which is what the industry asked for. And it will go into effect, all of this, by the way, goes into effect January 1st of 2026, at least according to the current set of regulations. And again, the data shared, and then this is different too. So in the original rule, all you were sharing was clinical data, sort of USCDI version 1, sort of that data set. But now it's going to be claims. So except for the provider remittances, again, we're not sharing payment information. Prior authorization, requests and decisions, and some new standards. So again, yay, FHIR for sharing data. It's also going to support flat file bulk, because wouldn't it be nice during open enrollment to be able to send all the new membership over, not just one at a time? Again, I think when the team saw this, we're like, okay, the only thing that we sort of hadn't seen before really was that prior auth, requests and decisions. All right, so this one, again, we sort of expected to see this. So this is prior authorization, and the goal is to try to streamline prior auth between payers and providers. And they're calling it PARDD, P-A-R-D-D, functionality. So prior auth requirements, documentation, and decision. It's actually got some really good workflow built into it, because what it's trying to do is solve some upstream problems with prior auth, like, do I even need a prior auth? Because every health plan has different rules around certain types of procedures and whether they need an auth or not. And even the type of health insurance plan you have may or may not require a prior authorization. So the first type of query actually says, do I need a prior authorization, yes or no? Wow, that's great information for a provider to know, because they now know I don't have to go through hoops. The second part of that requirement, documentation templates and rules, really great stuff too, because what it says is that I am going to push you the rules provider. And it doesn't have to go to the provider in their workflow. It could go to a care manager, a referral coordinator, whomever the right person is. But what it does is it says, here's the documentation you need. No, by the way, if you give me permission, I'll query your EHR to see if you actually have some of this documentation in your EHR. And if you don't, I can either ask you to submit it to me, or I can send you a questionnaire through a Smart on FHIR app that you can then enter the information in, which completes and satisfies the documentation, which means I can go to the third part of the implementation guide, which is the actual prior authorization itself, sending the auth number and then giving a response back. So I think it's a really interesting and hopeful, promising workflow. And again, there are new standards because it's a brand new rule. So it's FHIR, it's Smart on FHIR application launch, OpenID Connect is how you do the sort of security, and then the implementation guides are 3 sets of DaVinci, HL7 DaVinci payer-provider collaboration. They're doing a lot of work on creating a lot of these FHIR-based implementation guides, so that all that work has sort of been built already. The other interesting thing, though, is payers, except what's called a QHP, which are on the Federal Insurance Exchange, have to respond to a prior auth for a standard request no later than 7 calendar days. And it doesn't have to be electronically, but they've got to provide the response. An expedited request no later than 72 hours. And not only that, they're going to ask the payers to report those metrics publicly. And if you want to copy the slides, I'm happy to. All those metrics are the metrics that the health insurance plans are going to have to start to collect around prior authorization. I'm not going to spend a lot of time on this, but it's really interesting because concurrent, almost like within a couple months, CMS came out with this attachments rule. Now, the attachments rule sits on the X12 side, right? So this is a HIPAA transaction. This is a 278, 275 transaction. So that's how we do a prior authorization. And I always used to wonder, why do we fax and send PDFs so much around prior auth? Well, HIPAA actually says if you are going to do a prior auth electronically, you have to do it through an X12 278. You cannot use any. So guess what? If I drop to paper, I am not violating. If I pick up a phone or send it back, I am not violating HIPAA. And I'm not using the 278. And the problem with the 278 is it never supported attachments. Now, if you think about what I just said about documentation, template, and rules, a lot of prior auths require certain levels of clinical documentation to support the actual authorization. So this came out and it said, oh, we've now figured out a way to support attachments for 278. Yet on the other side, literally, parallel rule is saying, oh, but we could do this through FHIR and clinical data exchange. So it's sort of a conundrum, right? So which path are we going? And maybe it's going to provide some kind of glide path. So again, it's adopting a standard for healthcare attachment transactions, which would support claims and prior auth transactions. It would adopt standards for electronic signatures to be used in conjunction with attachments transactions, because again, often some of that documentation actually needs a signature with it. And then it's actually saying that for certain transactions, let's go to the 5010 version of X12 instead of 4010. Okay. So that's that one. I just want to mention that because I thought it was really fascinating that 2 rules dropped at almost the same time that was almost doing the same thing. The last one I'm going to cover, I have 6 minutes, so is ONC's latest rule. This came out during HIMSS. It is called HTI-1, and it's basically sort of updates to certification criteria. So it sort of adds on to the ONC interoperability rule. It adds some things to that. I'm going to just highlight. So it's just trying to implement 21st century cure, but make updates to the certification process and program to update things. So here are the major things it's going to do. There's going to be a new, what they call, reporting program as part of conditions and maintenance of certification. So this is actually testing. This is making sure you can report metrics around how you're certifying and testing your programs. Modifying the exceptions to info blocking, so I'll talk about that. Revising several of the certification program criteria, and it's very interesting. So there's a CDS, clinical decision support requirement, that already exists as part of certification. People don't know about that. They don't think about it a lot. They're updating that, and they're updating it for a good reason, because they're very, very concerned that there isn't transparency in how certain technology vendors are using AI. And so they're not saying don't use AI and don't advance sort of the use of AI and machine learning, but be transparent about it and let people know what you're doing and show them the data and the science behind the outcomes. They are proposing that USCDI will move from version 1 to version 3 by January of 2025. And then using the standards that are under the certification program to reduce burden and cost, which is always one of their goals. So this is the, so the ones, I'm going to talk about USCDI version 3, so it's adopt version 3 is the new baseline. So they're kind of piggybacking over 2 because they figure by the time the rule becomes final and gets implemented in 2025 that we should be past 2 and on to 3. So they're sort of doing it and saying, let's get to version 3. Up until December 31st, 2024, you can use either one. You can go 1, 2, or 3. But by January 1st, you have to be on version 3. And again, there are a whole bunch of certification criteria within the O&C rule that actually reference USCDI. So the implication is that you'll have to be on version 3 for those criteria as well. I talked about this. This is really cool. This is the, let's use AI and ML. I'm not going to read this, lots of bullets, and I have 3 minutes left. But basically, that's the gist. Let's get some transparency. Let's make sure that we understand the models and that there's, some knowledge and some science. Information blocking exceptions. So they've sort of changed how they've defined offering health IT, and then and health IT developer of certified health IT. The reason they did that is there was confusion in the industry that if I am a health system and I am offering certified technology to my provider network, am I offering health IT? Well, no, you're not a developer, and they were just trying to make sure people understood that. There's an infeasibility exception, and there's a manner and content exception, and then there were a whole bunch of requests for information at the end of the rule. So the infeasibility exception was trying to say that uncontrollable events actually had to have a linkage, right? There can't be like there was a flood, but it was 7 states over, but I'm going to claim that as an exception. I couldn't do it because there was a flood in a different state. So it has to be causality, right? That third party can't modify that EHI is infeasible unless the provider requests the modification of a business associate. So again, who can make those kinds of requests? The manner exception exhausted is like they're finally saying that if I'm really trying to meet you halfway about what's called the manner and content, getting it to you in some way that's sort of agreeable to both parties, and if I've tried these 3 parts that it's fine. I have met the exception. And then the manner exception has a TEFCA condition. It allows QHINs, participants and sub-participants in TEFCA, the ability to fulfill EHI requests from any QHIN in TEFCA using TEFCA means. So in other words, if I can't do it directly, but if I can get that data to you through a QHIN and through TEFCA, that is actually an acceptable path to providing that information as part of a manner to get you data. That's it. I have 43 seconds, but I'm happy to stick around and take questions. I'm happy to share slides. Thank you. I will ask somebody who can answer that question, and if not, give me your card and I'll put in PDF and send it to you. Happy to do that. But we may be providing it just generally to folks who've been to the conference. Yep. Other questions? I have 6 seconds. I know there's a lot. There's so much. So thanks, everyone.